Hi, this is Brian Kim. I'm going to share with you this case of a patient with a soft cataract, and we'll do double chop, cross chop, mechanical fracturing techniques, and then finally aligning this toric lens to axis 153. You'll see how I'm able to easily and precisely rotate this lens into the position with this technique. So I'm using a cotton tip to help center the eye. And then I'm using a corneal marker, which will help me to center and size my rhexis. I use a cotton tip to turn the eye, and then make my paracentesis flat to the iris plane, first on the right side, and then now on the left side, by creating that nice corneal shelf by being flat to the iris plane. This will allow me to achieve a self-sealing corneal incision. So I'm injecting intracameral lidocaine and then now some dispersive viscoelastic to coat the corneal endothelium. And then I'm using the cannula to hold the eye. And this is the triplanar corneal incision. I make it a vertical groove, place the blade into the deep part of the groove, use the cannula to turn the eye away, tunnel through the cornea, and then turn the eye towards me with the cannula and then go in. That's the triplanar corneal incision. So this is going to be my puncture style Capsulorhexis. I'm going to puncture with the forceps in the center, pull downward towards me. You can see the rhexis try to go towards the left, and with the teeth closed, I kind of tease it towards me, grabbing the right side of the tear, and then I'm starting the flap going around circumferentially. This is a pretty big pupil. It's important not to make the rhexis too big, which is easy to do in these really big pupils, big eyes. So I'm just very carefully grabbing and re-grabbing as I go. So I burp some viscoelastic out. This will be the Capsulorhexis hydrodissection technique. Place the cannula out to the contralateral equator underneath the rhexis edge. Point the tip down. You get a nice fluid wave come out. Decompress on the left side. Point the tip down. And then begin to spin the lens on the right side. I'm going to irrigate the surface of the eye, making sure the sleeve is the appropriate length. I use a chopper to lift the incision, go in with irrigation off to minimize Descemet's trauma. I remove the surface epinuclear material, which creates the epinuclear ridge. Go underneath the rhexis edge, under the ridge with the chopper. Point the phaco tip vertically, subincisionally. Crush the lens in half, that's the double chop. Place the chopper out to the contralateral equator, pulling it centrally towards the phaco tip, crushing the right heminucleus in half, that's the cross chop. I use some vacuum to pull the lens piece up, the first quadrant, and use mechanical fracturing forces to crush that lens piece, using the chopper to hook the second quadrant up, using mechanical fracturing forces and emulsifying the lens piece. I turn the second heminucleus in front of me, place the chopper out to the equator, pulling it centrally, crushing it against the phaco tip, and then using high vacuum to grab the lens piece, the third quadrant, and then emulsifying it. Doing the same thing with the fourth quadrant, but you see the epinucleus came up as well. I'm grabbing the anterior aspect of the epinucleus. It prolapses up nicely. Again, this is a fairly soft lens here. I'm removing some of that lens material off the cornea. Take the chopper out, push BSS in, take the phaco tip out, go in with the INA handpiece. Because the entire lens, including the epinucleus, came out fairly easily in one large piece, sometimes you can have some adherent cortical material here, so I'm making sure I go underneath the rhexis edge and very carefully sweeping side to side to see if there's any hidden cortical material. And then I'm using foot modulation to polish any lens epithelial cells as well. So I'm just going around polishing underneath the rhexis edge. And then I switch to the polish mode and I'm polishing the posterior capsule surface as well. So there's some subincisional cortical wisps there. I'm just being ginger to try to disengage that cortical material from the posterior capsule surface. And then peeling it off. Once it's clean, I'm going to go in with the BSS cannula and I'm going to flush the subincisional capsulorhexis. And as I do so, you can see there's some cortical material that's being liberated there. It's very important to keep the eye inflated when you do this maneuver. By doing it this way, I believe it's very safe. So I inject some cohesive viscoelastic to fill the bag. And as I do so, I go in through the other incision with the capsule sweep, start to sweep underneath the rhexis edge of the lens epithelial cells. First on the left side, and then do the same thing on the right side. I'm going to inject a single piece of acrylic intraocular lens into the capsular bag. I'm injecting the leading edge into the bag. I go in with irrigation off, activate irrigation, and then make sure the leading haptic is in the bag, and then make sure the trailing haptic is in the bag. At this point, I'm trying to determine what axis I have to place the lens in. And so I'm asking for the axis ring, and I'm going to set the lens to 153. So rather than going on the right side, I choose to go under the left side, because this will allow me to keep the position slightly counterclockwise to the axis. This will allow me to more easily turn the lens clockwise into the proper axis of 153. So right now the axis is about 180, and now I'm using the INA to gently turning the lens into the axis of 153. Now I'm removing all the viscoelastic from the anterior chamber, making sure that the bag is clean. And I can see here there's not much lens epithelial cells or cortex underneath the rhexis edge either. So I'm just double checking the axis. My marks are at 0 and 180. You can see here I'm at about 160 here, so I'm just using the INA handpiece again with the eye inflated. I'm turning the INA handpiece slightly down because it's angled upward. So if by turning it downward, I'm able to turn that tip a little bit more leverage to be able to turn the lens. So I feel like it's at 153. I push BSS with the cannula, go out with the INA. And by doing it this way and quickly inflating the eye, I feel like this helps to lock the lens into place. Very gently hydrating the incision. You can see my rhexis is a little bit on the big side, but I do have 360 degrees of overlap, which is nice. So now I use a cannula to push the lens into place. Now I'm going to check my axis again. I'm just making sure the incision is nice and sealed. The lens is in great position. Now I'm checking the axis again. 153 is my axis, and you can see it is pretty much bullseye. It's perfectly in position at the 153-degree axis. So, these cases of the toric lens, when it's a big bag and a big eye, there is a possibility that the lens can rotate, especially when you're inflating it again. That's why it's important to pressurize the eye, remove all the viscoelastic first, put the lens into position, and then hydrate the incisions and lock the lens into place. So I hope this was helpful to you, and I thank you for your attention.